Hello everyone. We are going to be talking about total parental nutrition and lines. The team members for this project are Katie Marsh, James Martinez, Hannah Jung, and Karen Ketto. What is a central line? It is a vascular access device. A catheter is inserted into various large veins with the tip ending in the cavo-atrial junction. Typically, an X-ray confirms this placement. It is inserted at the bedside or during surgery. It is used for various reasons, like long-term drug therapy, like antibiotics, fluids, and chemotherapy, administration of parental nutrition, and for hemodialysis. There are multiple advantages. There are no repeat punctures and decreases the frequency of accessing the catheter. It decreases catheter-related infections and reduces the overall cost. There are several types of central lines. The first is the PICC line, a peripherally inserted central line catheter, and it's used for several weeks or up to a year. It has a single or multiple lumen. Next, we have the non-tunneled central venous catheter. It is inserted above the skin and used for hemodynamic monitoring, cardiac output, and pressures of the heart. It is typically used for emergent care or trauma, and usually short-term. Next, we have tunneled central venous catheter. It is inserted through the subcutaneous, and it reduces the risk of infection, and it is typically used if a PICC line is inappropriate. Finally, we have an implanted port. It is also known as a portacath. It is inserted subcutaneously through the chest wall and can only be accessed with a Huber needle or a non-coring needle. It has a less risk of infection, less maintenance, and the central line of choice for chemotherapy. Now remember, IVs shouldn't be started on the same side as a mastectomy, lymphedema, paralysis of the upper extremity, or where a dialysis graft or fistula is placed. Now we're going to talk about central line care. The need for a central line should be assessed every day. A dressing change should occur every 7 days or as needed if soiled. This procedure is sterile. Patients must wear a mask and/or turn away during insertion or during the change of the dressing. All healthcare team and the registered nurse should wear sterile gloves, gowns, and a mask. A sheet will be placed on the arm with the site exposed. The site will then be cleaned with chlorhexidine gluconate or CHG. Then the insertion will begin. The priority nursing action is to assess for a pneumothorax. This is because it is the most common complication that can occur except for PICC lines. Oxygen in a chest tube kit should be available at bedside, and the nurse should assess for a chest pain or dyspnea. This is because it is the first sign of a pneumothorax. Nurses should always use 10 ml syringes to flush central lines because the pressure within it can rupture the catheter.
For central line education, for procedure and placement, the nurse will educate the patient on how the provider will insert the central venous catheter, and this will be at bedside or in surgery, and it will be a sterile procedure. Nurse will educate the patient on the placement of their specific type of central line. If the patient has chest pain during the insertion, they will need to alert the provider, as this could be a sign of a pneumothorax. Nurse will educate the patient on complications, which I will talk about in the next slide. Central line complications. For the PICC line, infiltration and extravasation are rare. Infiltration and extravasation are leakage of medication or fluids into the tissue. The difference between the two is that extravasation occurs when a vesicant damages the tissue. Collapsy is a less common complication as the insertion site is not on the chest, where bacteria is more likely to grow. Phlebitis is inflammation of the vein, and signs and symptoms of this include pain, the area will be warm, and redness. DVT, excessive bleeding, and infection can occur. Signs and symptoms of infection includes redness, swelling, warm to touch, and possible drainage. Non-tunneled and tunneled catheter complications include phlebitis, thrombophlebitis, and collapsy. Both have risk for pneumothorax and increased infection. With the tunneled catheter, kinks and tears are more likely to occur due to the smaller lumen, and nurses should handle the catheter with extra care. For the implanted port, complications include persistent pain, infection, dislocation, and clots in the internal chamber. The implanted port also has a less risk of infection. With all of these complications, the nurse should notify the provider immediately. The photo in the top left is an example of phlebitis. On the right is DVT. The bottom left is an example of extravasation. Discharge teaching for central lines include avoid excessive activity. The patient should not lift more than 5 pounds, as this can lead to catheter dislodgement or lumen occlusion. Activities of daily living can be performed normally. The client should alert the provider if any complications or worsening symptoms occur, such as fever, pain, swelling, or redness. If a patient has a portacath or implanted port, they can swim and bathe. However, the other types of central lines, they can't submerge in water. When showering, the client will need to put a plastic barrier over the central venous catheter to prevent an infection. The patient should be educated to not pull on their catheter and to avoid lotion around the catheter or insertion site. Patients should also be taught to keep their follow-up appointments.
Next, we're going to talk about total parenteral nutrition, also known as TPN. It's used as a replacement for all nutrition for patients that can't meet nutritional needs orally or enterally. So it basically is going to bypass the GI tract completely. It's delivered through a couple different ways, either a central line, PICC line, non-tunneled percutaneous central venous catheter, a tunneled central venous catheter, or implanted ports. Or formulating the TPN is done between the physician, a nutritionist who is specialized in TPN, and a pharmacist. Then the RN is going to administer the TPN. For the TPN infusion, you're going to need an IV tubing with a filter. You cannot piggyback with medications or blood, and you don't want to use a wide tubing. It can mix with the other content, and there's a chance for incompatibility. TPN is left in the fridge until 1 hour before you use it, and you're going to do this for a couple different reasons. The first one is if you leave it out for longer than an hour, it is at a higher risk for microbial growth. This is due to the high content of dextrose in the TPN, and you also want it to warm up. So infusing cold TPN could cause hypothermia, venous spasms, and pain at the insertion site. Next, you're going to check the contents of the bag before administration with the physician's order. You're going to make sure that you look at the labs, the physician's orders, and then compare it to the bag and make sure it all correlates and there's no reason for you to hold the bag. And then you're going to do the 10 rights of medication administration. TPN should have its own tubing and should be labeled, and it's changed per company policy, but usually every 24 hours, and it's delivered over 10 to 12 hours. You're also going to want to monitor your blood glucose regularly, around every 4 to 6 hours. It's very high in dextrose, so you want to check your blood sugar levels to make sure you're not hyperglycemic. And sometimes the physician will order to slowly increase the dextrose in the solution or to start a slower rate so the body can adjust. The nurse is also going to want to use an aseptic technique when accessing the TPN, so hand hygiene, sterile technique, and this is all due to decrease the risk of infection. Next are the contents of the TPN. So this is going to depend on the patient's blood levels, which are monitored daily. And once the blood is drawn and the labs come in, the physician modifies the orders and the pharmacy is going to prepare based on the physician's orders. So the TPN can contain fluids, electrolytes, sugar, amino acids, vitamins, minerals, lipids, fats, proteins. So some of the vitamins that can be put into the TPN is vitamins A, B, C, D, E, and K. The addition of the vitamins in the TPN gives the solution the yellow color, which is normal in TPN. Minerals that they can include are zinc, copper, chromium, manganese, and selenium. And electrolytes that are included are calcium, potassium, phosphorus, magnesium, sodium, chloride, and acetate. Next, you can also put medications into the TPN bag. So there aren't a ton that you can put in there because you have to make sure that it's compatible, but a couple that we do see a lot in TPN is insulin, due to the dextrose, and heparin. Heparin, you're going to want to make sure you're checking your PTT before administering the bag, and this is used to reduce the risk of catheter obstruction. Another thing to note is that only the pharmacist can add medication to the TPN bag, and no medication should be added after it leaves the pharmacy. Next are the TPN candidates. So who qualifies for TPN? Candidates for TPN are those which are in need of intensive nutrition support for extended periods of time and who cannot eat. So this can include someone with a cerebral vascular accident, trauma, or genetic anomalies. Those with diseases affecting absorption of minerals and nutrients are particular candidates include those with Crohn's disease, cancer, ischemic bowel disease, short bowel syndrome, and abnormal bowel function. So basically, one way or another, the patient can't swallow or their GI tract is not absorbing correctly, and we're going to have to bypass all of that and go straight into the central line and give this patient enough nutrients in order to thrive.
If the TPN is not ready from pharmacy or the TPN bag has gone dry, the nurse must do a few things. First, the nurse must obtain D10 water or D20 water until the TPN bag is available, and this should be ran at a similar rate to the TPN which was hung. The nurse must continue glucose checks to maintain safe levels of glucose for the patient. Once the bag of TPN is hung, The nurse should not attempt to catch up if the TPN is hung behind schedule. The nurse should also never stop TPN abruptly. Stopping abruptly can lead to an episode where the patient becomes severely hypoglycemic. This is known as diabetic shock. TPN complications and risks. One of the risks of TPN administration is dehydration. The nurse should assess the patient for hypotension, tachycardia, and dry skin. Fluid shift may also occur due to the extreme hyperosmolarity of TPN solution. Hyperglycemia or hypoglycemia can occur if therapy is stopped abruptly. Hyperglycemia occurs mainly due to the increased level of glucose in the TPN bag. Osmotic diuresis and hypovolemic shock are both complications of TPN administration, also due to the hyperosmolarity of the solution. Hyponatremia, hypercalcemia, and hyperkalemia are electrolyte imbalances that can be caused by TPN administration. Metabolic alkalosis may occur from TPN administration as well. The nurse must assess for a positive Chauvet-Stein and Trousseau sign, irritability, anxiety, muscle cramping, tachycardia, and paresthesia. Fluid imbalance related to cardiac or renal problems can result in fluid overload, CHF, or pulmonary edema. The nurse must assess for these symptoms as they can be life-threatening. TPN should not be infused in peripheral circulation because it can damage blood cells and the endothelial lining of the veins and decrease perfusion in the patient. Nursing interventions with TPN. The nurse should check the patient's weight daily along with accurate I's and O's, as 0.5 to 1.5 kilograms of weight gain per week may indicate a fluid overload. This is especially important in patients with CHF, cardiac, or renal problems. The nurse must monitor glucose, even if the patient is not diabetic due to dextrose levels, which are high in the TPN. There are certain lab results that the nurse needs to monitor. These include the BUN, creatinine, liver function tests, and glucose. The nurse must assess for signs and symptoms of infection or infiltration, as the TPN is not being administered in a peripheral line, but a central line or other lines which were discussed earlier. The nurse must change the TPN tubing every 24 hours. The nurse must always be sure to go through the 10 patient rights, as well as double-checking the TPN with the MAR orders, as explained earlier. Home use of TPN. Home use of TPN occurs for people who don't need acute care but still need nutritional support from TPN. The nurse must teach the patient how to check their blood sugar, how to change the tubing, how to change their dressings for their central line, the maintenance of oral health importance, signs and symptoms of infection, and how to record I&Os and daily weights. TPN at home has become more popular, and certain accessories have made this more possible, such as TPN backpacks, which help with ADLs. The nurse must also assess the emotional toll that TPN can have on someone's life as it affects their daily living.
The nurse would know re-education regarding central line care is necessary if the patient states the following. A. I can still perform my activities of daily living. B. I can't wait to start lifting heavy weights at the gym in 2 weeks. C. I will inform the nurse if my arm begins to swell. D. I will ensure all healthcare professionals clean the hub of my central line for at least 30 seconds. The answer is B. Rationale is that lifting weights more than 5 pounds can cause catheter dislodgement or lumen occlusion.
Question 2. You are working on the ICU floor and have a 45-year-old patient that has been on TPN for 3 days. You receive her daily labs and see that her sodium is 138, potassium is 5.1, calcium is 9.1, and chloride is 102. Her next bag of TPN comes, and you see that it contains 40 MEQs of potassium chloride. As the nurse, you know she is about to run out of her current bag. What is your next step? A. Continue with administering the new bag of TPN. B. Allow the current bag to run out and call the physician for a new order. C. Replace the current bag of TPN with D10 water and call physician and ask for a new bag of TPN that does not contain potassium chloride. Or D. Continue administering the new bag and ask for an order of KXL8. The answer is C. A potassium level of 5.1 is out of the expected range of 3.5 to 5, and so the potassium-containing TPN should be halted and the doctor should be called to avoid any potential cardiac or mental state changes in the patient.
Our last NCLEX question is: a patient is admitted to the medical surgical unit after being diagnosed with Crohn's disease. The patient is eligible to receive total parental nutrition or TPN due to needed extensive nutrition. Which of the following central lines can TPN not be administered through? Select all that apply. A. Intravenous catheter. B. Midline catheter. C. Implanted port. D. Tunneled central venous catheter. Or E. Non-tunneled percutaneous central venous catheter? The answer is A and B. The rationale is that both of the lines are not capable of administering TPN to the patient.